afternoon, everybody. And at the outset, I would like to thank the Diacon team who has uh, invited me to take a small talk on wound targeting wound biofilms and advanced wound modality. Now, this topic is actually should be covered in 20 to 25 minutes, but I will try my best to give a glimpse of what I have, what research is going on, and what is the new things in biofilm. So, but diabetic foot emerging new phase of diabetes, India is home to 72 million people, so we have twice the number of food to be taken care of. One out of four diabetic patients have lifetime risk of developing chronic wound. One out of five diabetic foot patients undergo amputations. And in India, about 2 lakh leg amputations occur per. This was presented in the IDF journal. So you have this different kinds of presentations, and you have to identify what is uh, which one is going to be a neuropathic ulcer or a vascular ulcer. If you saw the ulcers which are below, and you see this white, very classy biofilm, which is a white pearly thing, and when you do the debridement, you will get a recurrence in the next 24 hours. So what is a biofilm? So the biofilm is in nature a conglomeration or a polymicrobial infection with a core group of mature bacteria and a planktonic bacteria in the surrounding. This communicate with each other through water channels, and this kind of communication is called as quorum sensing, where the nutrients, oxygen, and genetic information is transmitted with each other. The newer research shows that there is an extracellular genetic material or chromosomal material which causes horizontal gene transfer, causing antibiotic resistance, causing different kind of extracellular polymer to be secreted, which covers the entire biofilm in such a way that it not only causes resistance to the bacteria, but even for your debridement, and it causes recurrence. So in short, this is about biofilm is a big thing. So there are about 70 to 80% chronic wounds which have infections of biofilm, and the biofilm composition, I just told you what is the composition. And what happens is this planktonic infection, which normally settles down in a decreased immunity patient, the host immune response is less, the genetic changes and growth of biofilm capable phenotypic changes occurs, and this causes antibiotic resistance. There is APS production, and there is a gene transfer, as I just informed you, and there is the host inflammatory response continues unabated. It doesn't go to the proliferative stage, and you have a chronic inflammatory stage with metalloprotein secreted MMP9 and MMP6. So this causes a chronic wound. Now, why this is not getting all right? Because there is a stalled non-healing wound. There is increased bioburden, destruction of growth factors present in more than 80% of chronic wounds. It's polymicrobial, very high resistance. Antibiotics are impenetrable to biofilms, and you require double dose of antibiotic. Sometimes we have to give avibactam and ceftazidime combination, which is the best combination now. It is come. We have seen now not only the pseudomonas, but we have actinomyces bomani and corynebacterium, which is also seen in the bone osteomyelitis, which are highly resistance, double resistance. So we have to combine debridement with negative pressure wound therapy with. Now sometimes we are now publishing a paper of use of vinegar in the wound for pseudomonas infection. Now these are the different types of biofilm that you see: staphylococcus, pseudomonas in the wounds, chronic wounds. You have chronic wound infection with enterococcus faecalis, but you have coagulous negative staphylococcus also in breast tissues. So if you have breast infections, and proteus species in wound infections and burns infections. Why are biofilms so difficult to manage? Chronic long-term infections, resistance to host defenses such as phagocytosis and killing, difficult to diagnose, frequently recalcitrant to antibiotics. So whenever you are giving a systemic antibiotic and your culture-specific antibiotics, you have to combine with the gold standard of debridement. With the first debridement has to be good. It is not that the biofilm is only superficial. You have deep biofilms in the tissue which you have to take care of, and you have to use irrigation, negative pressure wound therapy, and many other modality things which you have. You cannot be mentioned in this lecture, all of them. This is a typical biofilm that you see, white and pearly, and you will be surprised when you try to, as a physician, try to open it. So don't allow your assistants to do dressings. At least go and see the wound. That is why we have this foot workshops. You have to see the wound yourself. You have to assess the wound yourself. So we always discuss about the biology, treatment, review articles. What is new? So there are sensors, biofilm detection center sensors. We do microbiology cultures, DNA-based analysis, RNA-based analysis, which is conventional scanning, electron microscopy, PCR, all these things we are doing. But the new things which are coming are specific bacterial species sensors, pH sensors. So the pH in a biofilm is always low, acidic. Biomarker sensors, temperature sensors, enzyme sensors of lipase, and wound biofilm matrix sensors. Now this is something new in the horizon. Western countries, they are doing. In our IITs, people are doing for various other biofilms on innate objects. It will soon come in our medical line of treatment. You have fluorescence illustration of biofilm sensor with a color change observed in positively infected samples with fluorescence seen from sensor tubes containing different bacterial strains. So in Jaslok Hospital in Mumbai, we have a microbiologist who is doing this. So and I hope it will come. So optical, electrochemical approaches, sensors to indicate environmental parameters, different methods are available to measure the wound pH, which I just said. What is the treatment? So you suspect a biofilm, reduce the biofilm with the debridement, vigorous cleansing, and then apply an anti-biofilm strategy with a barrier dressing which suppresses the biofilm and decreases its recurrence. If you have to reassess this every time, if it is not healing, you have to go back to your basics of debridement. You have the newer novel methods of chronic wound therapy where we use ultrasound. Now this is very practical in big hospitals like Apollo, Raheja. We are using ultrasound targeted microbubble destruction, ultrasound assisted drug delivery, pulsed and continuous ultrasound. Now this can also be used by physicians. So if you have the capacity to buy ultrasound with debrider, which is very, very expensive, and then we are using silver nanoparticles, copper, at least in India. The other metal oxide based nanoparticles are still not come. The other microneedles, nano emulsions, liposome nanoparticles, and carbon based nanomaterials are not available in India. So the biofilm eradication treatment, if you are in a district place or in a village, you do a proper debridement with anti-biofilm property like using cadoxumaradine, or you should use ultrasound debridement with vancomycin. uh, you can use to debride the biofilm. Certain things which we use curettage to use to scrape away the underlying film and manage the pathophysiology gently. Continual debridement and negative pressure wound therapy, that is a combination, good combination. Ultrasound debridement I just said. Then there is something called as a chitosan, which is a biofilm wound management product, which is biodegradable, non-toxic, biocompatible polysaccharide, chitin polymer, scaffolds of chitosan, which can be used in different organisms, and it has a good results. So the other, for very cost effective method, sharp debridement plus silver carboxymethyl cellulose or silver, or you can use cadoxumaridine. This is the uh, paper published where Staphylococcus and Pseudomonas, which is more common, a very good result with cadoxumaridine. You have to know how to use it. That is the most important, how to use the cadoxumaridine. So I had recommended the company who was making the ointment about the difficulty of applying. Now they have the powders which you can be used. This is one patient, very extensive biofilm going into the deep. We had to do a 4-foot amputation. Still there was biofilm. We put cadoxumaridine, took the help of negative pressure wound therapy, and this is how the patient is. Now, I hope this video is running, but he is all right and he's walking. And he was so excited that when I was trying to take his video that he wanted to jump up and down or whatever, I do not know. It was not told to him. This is case 2, a young woman who went on the Pandharpur Yatra barefooted, and she got a very large burns with biofilm. This was dibridamide, again used cadexomeradine, and this was then negative pressure wound therapy done locally. And I'll take 1 minute more, and then it was grafted. So these are similar wounds. So the things which has also revolutionized diabetic foot management along with biofilm and other wound is negative pressure wound therapy, which decreases exudate level, tissue edema, wound volume decreases by micro deformation. Wound bed stimulation, wound edge contraction and granulation formation occurs. And these are foam materials. So the basic foam pore size is 450 to 600 millimicrons. We have larger foams now. The larger surface area will cause more absorption of the slough or the biofilm remaining, and this can also help. So these are some of the things which are practically used, not theoretically, in management of biofilm and management of large wounds. So wounds are in evolution, friends. Do not be pharma driven. So we have to see that the patient's wound proceeds from inflammation to proliferation and epithelialization. We have lot of things which are available. We have to use them judiciously so that the patient which comes to you is not only for the treatment but justice as far as cost effectivity is concerned. These are some of the significant adjuvant therapies: skin substitute, HBOT, topical oxygen, different kinds of toolays, certain antibiofilm agents, ultrasound debridement and offloading. Thank you for your patience.